Oh, there we go. Now it's recording. So with this, we are clearly focused on those aspects of our system that are directly or indirectly related to the distribution of those inequities. Again, both in outcomes as well as experiences. And along the way, recognizing the fact that in order to meet our obligations with respect to accountability, transparency, et cetera, as a government and as a health system, we do really need to measure and track and report back and share our progress on this. No question that so many people in our province and in this territory have been waiting for this work for a long time and have been hardened by our system for a long time and continue to be. It is imperative on us then to be able to be transparent and open about where we are, where we're going, and how we're doing along that journey. So how did this come to be? The basis for this work is actually legislation, which is unique, I would say, again, to my level of knowledge, and certainly beneficial from a government perspective, in that we actually have a weight of legislation behind the work that we're doing. In particular, the act that generated this work is called the Dismantling Racism and Hate Act. It was passed in the spring session of 2022 by our current government. And it does name the health equity framework as a specific deliverable in that act. So again, by virtue of being part of legislation, of course, it's beholden to those, I guess, sort of democratic processes and oversight bodies like the Office of the Auditor General, those sorts of bodies, which is a little bit different than, I would say, how work related to equity, diversity, and inclusion, and anti-racism and anti-oppression have been done in the past. And certainly, again, to acknowledge the fact that there has been and is a fair amount of work going on in that area currently. The difference, though, is that there was never a sort of central framework to capture and sort of to guide this work, right, which is, of course, what we're sharing with you today. But also that it was usually spearheaded by champions, by folks who had an interest, and often was conducted off the side of folks' desks with limited support or limited resources or limited mandate. And certainly by being found in legislation, of course, and by also being included in our government's health plan, which is Action for Health, under Solution 6 in particular in that act, in that plan. We do have a little bit of weight with respect to where this work is positioned and the influence it has, it can and should have over our system and all the other aspects that make it up. The other thing that we have, and this is part of our approach, is that the work that we're doing is not solely owned by government. Certainly we're accountable, and our minister is accountable for this work, given that it is legislated and given that we have that obligation under the health system as the sort of government representatives in that relationship. But we have developed this framework, and we are delivering this framework as a collaborative system. And so that means all parties, and I've listed a number of them here, who have direct responsibility to deliver services on behalf of folks who live in this territory, are party to the work that we're doing. So the Department of Health and Wellness being, of course, the government representative in the health system, the Department of Seniors and Long-Term Care, which obviously is a separate department with a separate minister, but certainly responsible for delivering a large aspect of healthcare services for long-term care and continuing care, amongst others, as well as our health authorities, Nova Scotia Health and IWK Health, and finally the Offices of Addiction and Mental Health and the Office of Healthcare Professionals Recruitment. All of those parties have different levels of responsibility, different areas of service delivery, different mandates, yet we all share a responsibility to co-develop and certainly deliver as a system on the pieces that have been identified in the framework. And so I generally pause on this because just to draw out the significance of the fact that we have that weight in legislation, that we have that weight with respect to our sort of system planning, and the fact that we're taking a collaborative approach that's really grounded in those same principles that I spoke to a minute ago. This is different and unique, and certainly I would cautiously optimistically suggest a more fertile place to start with respect to system change than, again, folks who are champions struggling against the tide of mandate and responsibility otherwise. So that's a bit of context around where we are and where we came from. In terms of the development of the framework itself, we engaged in a fairly robust engagement process that had a number of different components. It spanned about 9 or 10 months or so between the summer of 2022 and when the framework was actually launched in July of 2023. Pardon me, this included two phases of engagement. One, which was sort of an initial primary engagement, where we reached out to essentially anybody who would speak with us, primarily underserved, underrepresented communities living in this province and this territory, but also the general public, as well as partners within our system, both from the administrative and service delivery side in general, but also from folks who also represent underserved, underrepresented communities and currently work within our system. Certainly, they have a unique experience and unique perspective and important perspective to share around the work that we're doing here as well.
Eric, I am so sorry. I'm so sorry to cut in. Your audio is cutting in a bit, in and out. I don't know if there's any way to get a bit closer to the microphone, maybe.
Sure.
Sorry about that.
To see my face a little closer. No, thank you for letting me know. I appreciate that.
No problem.
Hopefully that's a little bit better.
It sounds okay now. Yes.
Okay, perfect. Great. Thank you. Okay, so just to rewind just very, very quickly, we've done 2 rounds of engagement to develop the framework. First round was really a general engagement with anybody who would who's willing and able to share their experiences with us with respect to the interactions with the health system, both as either a community member or a member of the public who accesses services through the health system, but also as folks who work within the system, provide services, who serve in administrative roles. All of those perspectives are incredibly important, and we wanted to gather as much as we possibly could to understand basically where we were starting from in order to create the framework itself. From there, we took that information, we synthesized, we themed, we did a little bit of work to understand what was shared with us and what we heard. And from there, took the results of that learning and shared those back with a smaller group, but a representative group of folks, to make sure that we really did understand what we were hearing, that we hadn't missed anything, that we were going in the right direction in terms of what we were taking from what had been shared with us already. And through that process, also, of course, had an opportunity to learn a little bit more from folks who either may not have had a chance to share their perspectives or could add to what they had already shared. And so through all this, again, representation is incredibly important. So we did have a chance to go right across our territory, our province, to be able to speak to folks both in cities and rural areas and corners of the province that don't normally have a voice. We certainly weren't complete in that effort, but we did as well as we could within the time and resources we had, and spoke to as many people from, I guess, different communities, for example, youth to elders, to understand the perspectives at various places along that spectrum as well, and many other characteristics. So through that, we gathered a lot of information. There was, and the numbers actually, and I keep saying every time I present this, I keep saying I have to go back and update this. So we have 75 sessions where we spoke with people directly. And it's actually more than that because we spoke to some groups and some individuals more than once. But a wide range of conversations, both internal and external to the system. Alongside that, to engage the public, we had an online, basically an engagement platform that we used to, again, solicit any information that folks are willing to share with us. And we had a great response to that with, I think, right around 1,200 or so 1,100 or 1,200 folks responded to that. And most powerfully, there was a section in that survey where folks were asked if they were comfortable contributing or sharing an experience that they had within the healthcare system. And about 550 or so folks actually contributed something. So we had a very deep pool of information to draw from. Challenging, no question, given the range of experiences that were shared, but deeply impactful and deeply influential over what we ended up putting together in the framework itself. And further to that, again, to address any barriers with respect to access that was internet-based, we had library partners put displays in their libraries central to communities all over the province to be able to facilitate any sharing that was not internet-based, community central and safe and accessible. So a lot of results from that. I should have said before that, we did a bit of homework to set up our engagement. So instead of going into these conversations saying, can you tell us for the 40th time, Community X, what your experience has been with the system? We wanted to acknowledge the fact that folks have and continue to do a lot of work to advocate to our government and to our health system on experiences that have been happening in their communities, some of the harms that have been done, and those taking their own time and their own effort to be able to organize that and submit that to either government or health system. And so we did as much as we could to gather that information together, listed a few examples in the top left quadrant of the screen to understand the current landscape as has been shared with us. Again, partially to ground our own understanding in advance of the conversation, but also to acknowledge some of the work that's happened in the dedication those folks have applied to the representing their communities, their experiences. And so we also looked at other frameworks and things, but at the time, there weren't many examples. There certainly more now, but there weren't many examples at the time of frameworks that govern this kind of work, and especially at the government level. And so, again, that due diligence was taken to inform those conversations. We approached those conversations by saying, this is what we understand. Does that make sense? And then inviting further input as opposed to starting from zero. Which we felt was just a more respectful way to approach those conversations. Alongside this, the other piece to this in the top right is the fact that we had cross-partner leadership on this. We had a couple working groups that govern various aspects, both the development of the framework as well as the data side of things. And we also had an executive level health equity partnership table that was providing general oversight and guidance to this work at the same time. So that's how we got to now. And at this point, I'm going to turn it over to Karen, who's going to walk us through the content of the actual framework. Over to you, Karen.
Thank you, Eric. So as Eric shared, we went through a robust engagement process. We really wanted to make sure that, one, we were respectful of folks' time, and we're taking advantage of the situation where we have legislative support to get community-driven feedback, but more importantly, community-driven solutions as well. Communities across Nova Scotia have been telling us through different channels over the years their different issues and challenges, and we made sure that we spent some time in our engagement sessions to ask about where the strengths are and what solutions we can implement so that our solutions are community-driven and we're not just imposing our thoughts based off of the challenges that have been shared with us. So that was a key component of this engagement. As you would imagine, through the numerous types of feedback channels that we had from our engagement that Eric shared about, we received tons and tons of feedback. And so part of our process was the analysis of that feedback, taking it in and breaking it down into some themes and seeing what top priority areas in terms of where we can start digging away at this work in a systematic and strategic approach. So what I'm about to share with you are just some highlights of some of the things that we heard. It is certainly not everything, but just for you to get a good sense of the themes and a good sense of where we're starting. So not exhaustive, but just a snapshot of some of this work. The first theme that emerged was patient experience. We heard from different folks across this province in underserved and underrepresented communities that ultimately they do not feel safe using the healthcare system resources. Many of these folks experience bias, stigma, prejudice, a lack of cultural awareness that impacts their quality of care. And this ranges anywhere from hurtful language, unfair treatment, insensitive questions, misdiagnosis, etc. We heard about the intersectional challenges with self-advocacy, presenting a need for additional supports or representation to help folks get quality care. Self-advocacy in itself is challenging for children, for youth who rely on their parents to speak or reiterate their issues to their healthcare providers. It's challenging for people who can't speak up or ask questions or defend themselves, in which children typically find themselves in. And so the identities in different equity communities create layers in the process that become barriers because of the way the system is designed. And so navigation and advocacy services are a helpful way for folks to gain effective care. An example that was shared with us was of a 14-year-old Indigenous boy who was sick and had trouble breathing. And the nurses brushed it aside under the stereotype that the boy was a drug addict. And it turns out that through further investigation, due to another nurse present from the same community who intervened, the boy had bronchitis. And so these are some of the stories that we kept hearing over and over again, that dismissive experience that folks were having, and the challenges with advocating for yourself in the system. Youth from different communities also reported that they're not treated well unless they exaggerate their conditions. We heard about the stereotypes around Black people feeling pain differently, and how these stereotypes are harmful and affect how Black children are viewed. And so some have to resort to exaggerating their conditions in order to get help or the attention that is needed. And we heard similar perspectives from Indigenous communities and other equity communities as well. That same needing to really emphasize the pain levels and the situation that's at hand. We also heard from Black mothers sharing their numerous stories of being neglected, ignored, dismissed as they seek care, and they shared about the direct impact on the health outcomes of their child because of this. And they shared things like delayed diagnosis and the effects of that, delayed treatment, compounding conditions as treatment is being delayed, resorting to self-diagnosis because the situation persists and the right treatment is not being undertaken. These are some of the things that, because of the experiences of mothers, also affected the outcomes of children. Stereotypes ultimately have been shared to be prominent in all stages of receiving care for different folks in equity communities, which have a deep impact on how they're treated. And ultimately, all of this contributes to high levels of mistrust in the health system. Next slide, please. And so, as I mentioned, we asked for community-driven actions and solutions. And so, high level, we heard the need for implementing a safe and effective system for identifying, reporting, and addressing these incidents of racism and discrimination against patients, as they're currently feeling that the channels available are either not appropriate or don't exist in some facilities. We need to work with underrepresented communities to address racism and discrimination in the health system facilities. So after reporting, where are the accountability pieces with that? What happens next? And lastly, to advance targeted solutions to address acute issues in specific communities. One of the things that we kept asking ourselves as we go along the work in this framework is, what about now? What happens in the interim as we are developing solutions, as we're going full steam ahead with this framework? What work is on the go, and how can we track it? How can we amplify it for community benefit? So I'll just share 2 examples of initiatives that are on the go. And one of them is Healthy Minds NS, which is a mental health initiative, an online hub that is available for youth in Nova Scotia to access it for mental health resources, connecting with peer support communities, and managing their mental health with cognitive behavioral therapy courses available, and many more. The second example is smudging in healthcare facilities for family rituals. Smudging is an act of wafting sacred smoke over one's being. According to Indigenous peoples and other communities across the world, this practice involves sacred smoke being burnt from medicinal or sacred plants, and it has many benefits. It's used for cleansing purposes, blessing purposes, and it's important for different family ceremonies, like when a child is born, when a patient is facing serious illness, or during the final moments of life. And so mothers and children of Indigenous heritage and others that also practice smudging can now do so at our IWK Women and Children's Hospital. And I would also like to acknowledge and give credit to the Indigenous advocates, elders, and community members that did not waver until they saw this win come through for their community. The second theme, so the second bucket of work that emerged from what we heard, was issues around health human resources. So while we did extensive work engaging with the communities across this province and the general public, we also engaged the health system professionals at the same time. And so we took note of the feedback from them, but also during our community sessions, there were some folks who maybe had left the health system and also had some important feedback to share with us as well. So we took all of that. Overall, we heard that from a representation standpoint, the system doesn't reflect the diversity of communities across this province, especially at the leadership level. There are minimal pathways for exposure, for experience for children and youth to fully understand the full scope of health professions that exist, and also have the opportunity to explore and potentially see themselves in these roles. We heard in numerous sessions that there's a lack of cultural competency, and the system continues to perpetuate itself with low retention rates for equity staff who often leave because of incidents of racism and discrimination and the burnout that comes from that. We heard about the issues of newcomers to Nova Scotia and getting their credentials recognized, and the additional layers that settlement poses in bringing different challenges due to the underwhelming supports available. Ultimately, health professionals reported not feeling safe in our system, and the need for different supports to ensure that they do feel that way. Some of the key actions that emerged from this work were advancing training in anti-racism and anti-oppression principles, trauma-informed care, person and family-centered care, and cultural competency or humility as well. We're also steered in the direction of applying an equity-based approach to health workforce recruitment, which is very, very important in getting that representation that we would like to see in the system. I'd like to share some examples of some work that is actively happening in this space. In our department, we have a leadership equity achievement program for mid-level professionals to get exposure to senior leadership, hear from them, hear their perspectives, and go through mentorship sessions to build those skills that are needed to get to those senior leadership positions and be able to have that voice at that level, which is an exciting program that is in its pilot phase, and we're hoping that we see it continue. Another example is the Black Youth Development Mentorship Program. This program started in 2021, and it's a program geared towards Black youth in grade 11 and 12 to give them early exposure to different careers through the provincial government. Department of Health and Wellness has had a special attention towards this program since it started. We've been taking students every year, and we continue to grow our numbers and have now doubled them since we started. So providing that early exposure to a different aspect of health at the government level. And then last example is the Equity Youth Health Experience Program, which we piloted in 2023. This is a program that is funded by Departments of Health and Wellness, We provide funding to community organizations and that have health-focused initiatives or other health regulators or health research bodies or health institutions to provide those internship opportunities. Again, early exposure for the grade 11, grade 12 level, or first year post-secondary to get the experience in the healthcare field, to get the exposure to the different professions available. That pilot last year summer was successful, and we're happy to share that further funding has been provided to expand this program so we can have more students that can get access to this program across Nova Scotia. So these are some of the things that are on the go, and we're hoping to build on more of this as we go along. The third bucket of work is around health system policies and practices. From community feedback, we heard that health system users are not often sought or gathered in terms of input, and that input is sometimes ignored in the development of policies and services. So quite often engagement is on folks' maybe lived experiences or the challenges that they're having, but not necessarily in terms of the service delivery and shaping or structuring a program to make sure that it's effective for the communities in which it is intended to serve. And so this has come through as something that is important for communities and for the solutions. So we're investing in the right ways and making sure that we don't have to keep restructuring work and making sure that we're getting it right, or at least as right as possible the first time we do it. Second thing was better race and diversity-based data to be collected in order to hold the health system accountable and to inform planning decisions. And some of the key actions out of this is to ensure that EDIRA, so Equity, Diversity, Inclusion, Reconciliation, and Accessibility is the acronym. Those related tools and processes are used when developing new programs and policies, and that we're also going back to review audits of existing programs or services and policies that have already been developed and using those same equity-based approaches of EDIRA and anti-racism and anti-oppression to revise and make the changes. So we have to look forward, but we also have to look backward and restructure the ways in which we do our work to ensure that it's equity informed. Just as an example, the IWK, Children and Women's Hospital, provides programming and health services. And so, such reviews and audits helps to ensure that the programs are patient and family centered. So these reviews really help us to identify the gaps, to identify the opportunities, and to measure the impact and the improvement in keeping children as the focus. And lastly, identifying opportunities to build or improve internal health system data sources so we can have Nova Scotia informed solutions and not always borrowing data from other jurisdictions, so we can have more targeted, more accurate, more effective solutions. I'll pass it back to Eric now that you've heard about, kind of what happened in the engagement process, what work emerged out of that. We are now in the implementation phase. We're going full steam ahead. So Eric is going to share about what some of those priority initiatives look like for us for 2024 and 2025.
Excellent. Thanks, Karen. Yeah, absolutely. And so certainly even what Karen has shared with you all today is, as she mentioned, a snapshot of some of the pieces that emerged through the framework. And across those three theme areas, there are 35 specific actions that are named in the framework that pretty much equally distributed amongst those three themes. So about 11 or 12 actions in each. And you obviously can tell, given the scope of the work that we have here, there's no possible way that we could do all of those things all at the same time. Nova Scotia has a lot of great qualities, but certainly swimming resources isn't one of them. And so we have to be very deliberate and very focused on how we prioritize and where we start within the work that we have in front of us as the framework plays out. And so what I'm going to share with you now is essentially what we've started. And in fact, we've just kicked off some of these projects literally this week, which is very exciting to see these pieces moving forward. And I should say, just in brief preface to this, since the framework was launched in July, we've spent a lot of time bringing health system partners together to understand exactly how and what to prioritize. Recognizing again that we can't do everything all at once. Recognizing that there are some pieces to this framework that are so significant that they require a system-level intervention. And that means generally all 6 partners at once working on solutions and implementing across the board. With another recognition to the fact that given organizations' different mandates, they may have areas where focus is required within their own organization, and that can happen independently of that system work. But these are the system-level initiatives where we started from through that prioritization discussion. The first, and probably not surprisingly, is the fact that we need to look at our health system patient and family reporting process. As Karen already spoke to, the systems, we do have systems in place, but from community's perspective, at least, or folks who have used that system, it is not particularly effective or safe for many people to use. And as a result, and again, Karen spoke to this a little bit too, that system in particular does not have the trust of community in particular with respect to racism discrimination to adequately find a solution that's going to be acceptable. And so that's a significant piece that we're looking at currently. Second is a focus on workplace racism and discrimination. So the entirety of the health human resources theme that Karen walked you through a minute ago has various elements that all relate back to this particular theme. Certainly cuts across all the domains related to policy, process, and everything else that governs and administers our system. But we also know that, and one of the most prominent themes, of course, is the fact that there are so many people within our system who identify as part of underserved or underrepresented communities who are carrying the burden every day of that racism and discrimination that they may experience intentionally or unintentionally. And that has so many, unfortunately, negative impacts, of course, on their lives and their livelihood and whether they thrive or not in a particular job, and ultimately whether they stay in that position within the system. And as Karen already mentioned, a lot of times they don't, and for good reason in many cases. And so we also learned within this that there are some central components that are not where there's some gaps, I think, that are present within our system, according to folks that we spoke with. So managers, like managers on the floor, for example, a lot of them spoke to the fact that they don't necessarily have the tools or processes or supports required to really address issues of racism and discrimination within their teams as they arise. And so that's obviously a central component to the culture that's present in those service delivery settings, and what's possible to protect and foster the safety of folks who are working in those environments. So we have some work to do there, certainly. From a data perspective, and I'll say for both the first and second initiatives that I've just described, there will be a significant data component to both of those, as in both of those are, I would say, foundational pieces of information that, frankly, our system doesn't currently have with respect to how it operates and to what extent racism and discrimination is permeating our system. And so without that, it becomes really challenging to understand, frankly, what to do from a policy perspective, or what to change, or where to focus. And so as we go, and as Karen mentioned, we have a distinct lack of information related to racism, discrimination, and equity-related information in particular. And that's something we need to remedy. And we'll be doing that through the first 2 projects, but also the third, which is what is the actual composition of our workforce in Nova Scotia with respect to equity and other identities. We don't actually know that we know that to a certain extent, but certainly not to an extent that I think would be comfortable with from a statistical standpoint as being representative of our functional workforce composition. And so we're exploring some options as to how to get better information on that front, again, as a foundational component of health human resource work. The fourth piece is really interesting, and this is what we're trying to stand up around as we move through some of these challenging pieces of work. We recognize, again, that we have limited resources, but we also recognize that we haven't necessarily tapped one of our province's greatest resources, which is the academic sector. You know, our province is small, but it is blessed with a large, relatively large per capita number of academic institutions and a great range of expertise within this area. In fact, the National Collaborating Center for the Determinants of Health is located in Nova Scotia at St. FX University. They have produced wonderful information and guides and resources over the years within this area, and they're literally in our backyard. So we haven't done as much as we could to leverage those and involve the academic sector to the extent that we could. And so what we're trying to stand up now is a partnership between our health system partners, the folks who are doing this work and carrying it forward, with the community partners who, of course, have been engaged all along and will continue to be engaged through the initiatives that we're standing up. Again, providing advice, guidance, expertise, as well as those academic partners to collaboratively start to tackle some of the major challenges and challenging questions that we're going to be dealing with over the next bit. And finally, we've drafted as a system now for internal use at this point, a health equity framework charter. And this is meant to be a complement to the actual framework itself, which of course lays out the components that we're speaking to. But it's more focused on the application of those principles around equity, diversity, inclusion, reconciliation, accessibility, anti-racism, anti-oppression, and how we work as a system to actively incorporate those pieces into our administrative and daily work. And so in some sense, it's an obligation for us to all work together using those principles and applying those principles in ways that make sense within our system. But is, like I said, a complement to the actual work that goes into the implementation of those initiatives as we've described. So we hope that that's a little bit of a guide, a little bit of a reference, sort of cornerstone in terms of our approach, so that we're doing the work and moving it forward, but in the right way and in a respectful and engaging way as well. So that's just a snapshot of some of the pieces we're starting up in this fiscal year. There will be others that will come on over the course of this fiscal year, of course, and beyond, but that's where we're starting. These are the pieces that we consider as really foundational, like really critical pieces within our system that need to be addressed. And foundational from the sense that some of the work to come will certainly build on these pieces of work as we get a little bit more mature and advanced in this area. So that's the extent to what we wanted to share with you today. I really appreciate you hearing us out, and very happy to take any questions that you have and to discuss and provide any other insight we can. Thank you so much.
Thank you so much, both of you, for this wonderful presentation. Now is the time, everyone, if you'd like to, if you have any burning questions for Eric or Karen, please do so right now. Type it into the chat box. Oh, I think we just got one in here from Cindy asking, does Nova Scotia Health collect race-related health data?
As a matter of fact, we do. We have an initiative called the Fair Care Project, which collects ethnocultural identity as well as language as part of an opt-in process that's associated with the, well, in Nova Scotia, it's called Medical Services Insurance. It's a provincial health insurance card renewal process. And so folks are sent a form, or they can do it online to identify both ethnocultural background and language. And that information will be, again, collected as per that process. So a couple maybe potentially useful things to understand about this. We're not at a place yet where that information is usable because we're certainly on the road, but we haven't built up to a place where there's a pool of data that's large enough to be able to use safely. And so we've had right around 25% of the province's population, I think at last I heard, who have opted into this, which is a significant number. It's been about a year and a half since it launched, so we're slowly growing. But I think in order to have a robust enough sample size to start using for system planning purposes, we have to be in the 30 to 40% range. My stats are a bit rusty, that's what I've been told. So it's probably going to be at least another 6 months to a year before we get to that level. And the other useful thing, or not useful, interesting thing about this was that the ethnocultural identifiers that are listed in that in Fair Care were developed largely through a community collaborative process where the CIHI data standard for ethnocultural identity was actually adapted to fit the Nova Scotia context. So, for example, African Nova Scotians are a community that exists only in Nova Scotia. That's not represented in the CIHI data standard, yet as a significant historic community, a set of communities within Nova Scotia that needs to be represented. And so that's only one example of some of the adjustments that were made to that data standard. But it was quite extensive engagement process led by community that fed back in to develop the standard that was used in the Fair Care project. So hopefully that gives you a bit more information about that. Thanks for the question.
Yes, perfect. Thank you. I think Krista has a question for you as well.
So perhaps a question, but probably, since this is my province, a little bit of an addendum to some of the work that is also ongoing, although the Fair Care project is underway and will take some time to develop trust with our communities, is best, as Eric said, led by the communities, working with the communities, where the communities say, this is the data that we need and this is why we need to be included, so that they feel ownership. There are some longer standing individual patient population identified groups in partnerships. So there is a maternal newborn partnership with a number of our Indigenous communities called the Twigan Project. The reason for that project really was around giving ownership of understanding maternal and newborn data to the community, so that it isn't the healthcare organizations or the government saying, here's what's going on in your community and here's where you need to work. It is, here's our community information, here's us looking at what's important to us, here's us as a community, and I'm not at the community, it's their community, looking at the data to say, here's what we need to empower our community to look at how we want to move things forward in the community. So a number of those, I'm familiar with the maternal newborn one because that's the area I work in. I know that there are a number of other initiatives like that. But what we really want to get to is the place, as you say, where we have enough understanding of what our province looks like, enough trust within our province that together we can start to do some of that planning. So this work, the one thing I want to give a shout out to Eric and Karen for is this framework work. The really unique thing in my time in health in Nova Scotia was this was done in partnership with government, the health organizations, the deliverers, and the communities. And it has, as Eric says, a very different feel. We're not way down the road yet, but we're on a road that feels a whole lot different and better. So thank you to you guys for representing us well.
Like Dr. Chango, thank you for that. Yeah, it does feel a bit different, and you know, we have so much road left to go. We are literally, and in some cases actually with these initiatives, literally day one of having launched. So it's very early days. Yet, given the conditions, I mean, the mythical policy window that government people throw around, we do have a significant opportunity here, and I think, despite the fact we have a long ways to go, it'd be remiss to not acknowledge that opportunity we have. So, thank you for that.
Absolutely, agreed. Thank you, Dr. Jangard.
Wonderful. Just one last check to see if anyone else has any questions for our panelists today.
Or comments.
Or comments.
Yeah.
Open to comments as well, for sure.
Happy to chat.
I don't see any Jane Hammer, please go ahead with your question or comment.
Thanks, it's Jane Hamer. I'm calling in from New Zealand. And I was just wondering, when you say you're at the beginning of your implementation phase, like day one, have you got processes for evaluation?
So it depends on the initiative. Right now, we have, and I guess generally refer to this idea, but we have data-focused teams, and that includes evaluation as parallel to some of the big initiatives that we're launching now. And so part of that includes the development and implementation of those data standards that go along with those, for example, patient reporting systems. Just as one example, that system right now, the current system in place, does not readily allow for racism or discrimination related experiences that are shared with our system to be extracted and synthesized in any real way. That's a significant limitation within that system for obvious reasons. And so the data components, the data focused teams for this will be looking at those components and making sure that those systems are built in whatever future product we design and implement as robust as we possibly can make it. But at the same time, understanding from a process perspective how things are going and assessing against as we go. So short answer, we don't have anything in place at this very moment because we're still scoping out the nature of the work itself. But that's within the scope of those data focused teams that are going alongside as party to those bigger initiatives. So sorry, a bit of a non-answer. I apologize. I wish I had a better answer for you, but it's still too early for that, unfortunately.
And within individual organizations, there is some plans for, so for example, in our organization, looking at our inclusive hiring practices and setting some goals for inclusive hiring and actually measuring and reporting on them. So there is some of that already in place, depending on which part of the system that you're in. So some of these, as Eric said, are big province doing it all together. Some of the organizations have a focus on one or another where they're a little further down the path, perhaps, in the framework. So it varies a little bit by the initiative, by the organization, and by where we are as groups together. But the most cohesive thing is we're all aiming toward the same spot. So lessons learned in a smaller organization like mine can then be applied to some of the larger organizations or to long-term care, for example. So that conversation is good because we're not trying to all reinvent the wheel every time.
So I guess my question is all the data, as it's iterating, is the data being collected back at a central place so that you can be sharing and knowing that an intervention is actually making a difference for the people that you are hoping to support, and that you can share that in a meaningful way as it's iterating out?
I firmly think that is the hope, absolutely. Because ultimately, as Dr. Jangard mentioned, we have a need to have evaluations that are specific to the initiatives themselves. And we have a need for, and this is where it starts to interface with those broader system pieces like Action for Health, the broader government health plan, where there's robust reporting processes at that level, more of a population level as well. So we need to understand if and how the needles are being moved at multiple levels. But ultimately, as you pointed out, the people, the patients, the families are at the center of this. We wouldn't be doing this work if we didn't hope that the experiences, the health outcomes will be improved. And so that is, again, a core focus of the data components that will be developed alongside those major initiatives. And again, sorry if I've made too fine a point in this, but part of the reason why, one of the factors that led us to start with these initiatives that I just referred to is the fact that they also are major data sources for the work that we have going forward. The flip side of this is that we have very, very little equity focused information within our system currently. And I mean very little. And what we do have is either organization specific or held outside the health system, like for example, with a regulator or with professional association or union. And even in those cases, sometimes it's opt-in for self-identification, sometimes it's not, sometimes the categories are different. It's a very mixed bag and a very respectfully unhelpful landscape to deal with. And so our hope with many of these initiatives is to standardize as much as possible across all of our health system partners so that we do have lines of sight with respect to data that we can use to start making some of those inferences and observations and conclusions around the impact on patients. So I hope that answers your question. It's further down the road, but that's certainly our intention.
Wonderful. Thank you so much. Karen, I think we're going to be heading back to our main stage soon. Did you have any final words you wanted to share with everyone before we wrap up?
No, I'm good. I just want to thank everybody for coming to this session. We have a lot of work ahead of us, and we're excited at the opportunity to make change and impact for all Nova Scotians to have better access to care. And so please continue to keep connected to this work, and we'll stay tuned with your initiatives as well. Let's keep connected and let's work together where possible. Learn from each other. Thanks, everyone.
Thank you. Thank you again to both Karen and Eric today for this really wonderful presentation. We are going to be automatically brought back to the main stage in just a moment, and then we're going to head directly into a 15-minute break. So just come back to your screen at around 2 p.m. Eastern time, and we'll begin again at that point. So thank you, everyone.
Thank you. Bye.